Welcome to our web conference, Contact Investigation in a Congregate Setting. Today's program is sponsored by the Northeastern Regional Training and Medical Consultation Consortium. Today's presenter, Mark Woolman, is a program manager for the Tuberculosis Control Program at the New Jersey Medical School Global TB Institute in Newark. He has 35 years of experience in public health, both in the field of tuberculosis and sexually transmitted disease. He has written and contributed to a number of publications on tuberculosis in field and contact investigation. Mark?
Thanks, Valerie. Hi, everybody. Today we're going to review some of the elements of the congregate setting investigation with emphasis on 4 basic components. I think a good place to start is to define a congregate setting, and I think there's various ways to define the setting, but I think simply put, a congregate setting is an environment where a number of people meet or gather and share the same space for either a limited or extended period of time. I think the terms limited and extended in italics because as TB controllers, we know that these words are very vague and meaningless to us unless they're clearly defined. We also know that CDC and their guidelines for contact investigations that were published a year ago purposely avoided defining the cutoff points for duration of exposure and left it up to states to define on their own the cutoff points. However, in congregate setting investigations, time or duration frequency of exposure is only one element or characteristic that we investigate. So I'd like to ask participants, can anyone tell us what else we look for when conducting a large-scale investigation besides exploring duration frequency of exposure?
Environment.
Environment, good. What about the environment? Tell us. What specifically would you want to know about the environment?
Airflow, how large or small it is.
Characteristics we'll be looking for. We have time. We have environment. What else would we be interested in finding out about a large-scale setting?
Health status, their health risk.
Contact risks, exactly. What about the contacts would you like to know?
Immunocompromised, HIV positive.
Okay, good. Children, elderly, exactly, very good. And so we have time, we have contact risk, we have environmental place of exposure. And what would be the last characteristic that we'd be looking for? Actually, it's the first one that we'd be looking for before we even initiate the investigation. It would be to know more about the index case themselves. Are they infectious? If they are infectious, how infectious are they? Are they positive on smear or negative on smear with character disease and cough? Are they 4+? Are they 1+? These are things that we need to know in addition to the time period of exposure. Okay, so these are some of the more common investigation sites that I think we're all familiar with: child care, preschool centers, correctional facilities, houses of worship. I find houses of worship very interesting because they can range from the conventional traditional church or synagogue or temple to the storefront church, hospitals and other healthcare facilities, schools, workplaces. As I went through some of the registration material, I saw that many of you had experience in working in some of these folks. Initiate a setting investigation. The information collected from the medical record review and index case interview is necessary for the index patient, and this is on college health history. But what specifically, when we do the record review and interview the patient, what specifically are we looking for in terms of bacteriology, X-ray findings, and symptom history? Well, some things we're looking for, of course, in X-ray results would be cavity or non-cavitary disease. We'd be curious about bacteriology results, smear positive, smear negative, and certainly symptom history would be a cough. All these could indicate the need to consider initiating a large-scale investigation. Certainly, the infectious period needs to be established in accordance with CDC guidelines. The healthcare worker estimates the period of time that the index case was determined to be infectious. I put the word estimates in italics because, as we all know, the calculating the infectious period is really not a precise method. It's really an estimation of when we think the patient was probably most infectious. But it does allow the healthcare worker to focus questions to the patient for purposes of identifying high-priority contacts and all exposure sites. I believe that we cannot conduct a quality investigation or a quality interview and investigation without establishing a fairly accurate infectious period. Hopefully, many of you have read the guidelines that were published last year from CDC. Can anyone summarize what the recommendations are for establishing the onset and end date of the infectious period? Well, essentially, the infectious period onset date would go back probably approximately 90 days to 3 months from either onset of cough or onset of diagnosis, and the infectious period, the end date, would be calculated based upon a couple criteria. One would be greater than 2 weeks of treatment, reduction in AFB on smear, reduction in abatement of symptoms, and one thing that's not listed in the guidelines is when contact is broken. So if someone's admitted to the hospital on a particular date and put in airborne isolation, we could theoretically use that as the end of the infectious period. If sufficient program resources are available, the on-site assessment of the congregate setting should be initiated. If the index case is diagnosed with suspected or confirmed pharyngeal or pleural TB and presents with a smear-positive respiratory specimen and/or capillary disease with cough, as we just alluded to in the previous slide. Of course, everything is done by a case-by-case basis. If a patient is 1+ on smear or rare or less than 1 on smear, that might not be reason enough to initiate a large-scale investigation. Certainly, we would be waiting for a PCR if that is done in your labs. But just because someone is smear positive doesn't mean we have to run out immediately and initiate a large-scale investigation. But those are flags indicating the potential for transmission. And the key here is if sufficient program resources. We realize that many programs are well-staffed and can do these on-site assessments. But other programs may be staffed by one person or one nurse with other responsibilities in addition to TB, and to do these on-site assessments may be a strain on the program. The current CDC guidelines recommend that all potential settings for transmission should be visited within 5 business days of initiating the contact investigation or upon identification of setting. I was very pleased to see that CDC had recommended that. We believe that transmission should not be regarded as an isolated incident confined to a limited area such as the household, but rather transmission is an event that can occur in various sites such as household, social, recreational, workplace, and school. And I know that many of you have been involved in large-scale investigations, and we've all seen transmission in these sites in addition to secondary cases. Based on your experience, how would you, as a healthcare worker, explain to the patient the need for us to conduct a large-scale investigation when we know full well that most patients do not want us to go to their workplace or school? Well, one of the things that we could say to the patient is that we're certainly looking for transmission from the patient, but also we're hopefully going to find the source of their disease. And as far as the purpose of the meeting with site management, we would explain that despite the index case giving us names of contacts, we would like to meet with management to get their assistance in perhaps identifying more contacts that were overlooked or neglected by the index case. Now, depending upon individual program standards of practice, the request index case to sign a consent form authorizing disclosure of confidential information such as identity and diagnosis to site management is done on a need-to-know basis. And I'm wondering, CDC did recommend a year ago that states who do not use consent forms should consider formulating them and using them and having patients sign when needed to release their identity to a large-scale site. So I'm kind of wondering out there, how many of you use these consent forms? How many of you have had patients sign them authorizing disclosure of their identity?
Excuse me, can you ask that question again, please?
Yes, I can. Well, the statement is that depending on individual program standards of practice, request the index case to sign a consent form authorizing disclosure of confidential information such as identity and diagnosis to the site management. That's done on a need-to-know basis. The question is, of the participants listening today, how many programs utilize these consent forms, and what is your experience utilizing them?
I think almost all the programs use it now. And then in New Jersey, we as the state use that, including Laramore and other places that, I've been affiliated with the Middlesex, Somerset, we all use the same kind of form, to have patients, sign for the consent to disclose the information to the supervisor.
In New Jersey, has been using consent forms for about 5 years now, and to my knowledge, they're used very successfully. Most patients do sign the consent forms. I only can think of 3 patients the last 5 years here at Newark who refused to sign the consent to give disclosure, site management. If the index case refuses to consent to disclosure, TB programs must either comply or breach confidentiality, threatens the health of the public. And certainly, in the 3 cases I'm thinking of, their names were released to management because they were highly infectious, and we felt as if that the rights of the public outweighed individual rights to medical privacy.
Before you go on, could I make just a comment on that work site consent form and the patient signing the forms.
Okay.
What I've encountered was I tried to explain to them that, yes, we would like their permission and to work along with them to notify the management and what we require of management as well. And I've still encountered resistance with those forms. And although they resist, I've explained to them because of the public health risk that we have to anyway. So from time to time, when I get that far, then I find that a little bit more education and I can get them to comply with signing the form.
Yeah, I think patients would have a reluctancy to sign over consent to release their identity after TV, but I think you're right. Education, explain to the patient the reason that we need their name is to conduct a quality investigation. If we go into a school with 1,000 children, we don't want to test 1,000 children unnecessarily, so we need the names of the patient to release to a principal or medical director of the school system, so we can take a look at the class roster and really determine who really needs to be tested rather than test people unnecessarily.
Can I just say something about the consent form also? Sure that the name that the patient is using on the consent form is the same one that he has with his employer, and sometimes they use different names.
Yes, that's true. We don't want to have anyone's alias down there if they're using different names. We need to have the correct name. So when we go to the workplace, or usually at the workplace when we have an alias, we have a situation a couple years ago where someone used an alias, and we went to the workplace and management could find no record of this person, but we found out the person was using a different name. All right, so this is a table that really addresses some of the more common congregate settings of interest by age group. For adolescents, adults, and elderly, we would want to have the healthcare worker ask very specific questions to the patient as relates to the infectious period most of the time. So we want to talk about houses of worship in all three groups.
Mark?
Yes.
Anthony Lloyd from Philadelphia.
Hi.
How you doing?
Hey.
Can I ask you a question? Issues that we may come across is patient confidentiality in the workplace regarding the employer itself. How do you get around that? Find the appropriate person to speak to. Yet still, there's always an issue of patient confidentiality being broken. Do you have a standard form that you would give to the employer?
Well, you mean for management?
Right.
Yes. Actually, it's a good question. I'm going to get that in a couple of slides, but this is it's a two-part thing. We have a patient sign a consent authorizing disclosure if needed. And then when we go to the congregate setting, if we feel it's necessary to release the identity, then we ask management to sign a management agreement form to maintain confidentiality. So we can get those forms to you, and you can take a look at them and adapt them in any way you think is necessary. Okay, thanks for asking. Getting back to the table, so for all three groups, adolescents, adults, and elderly, we're going to ask about travel during the infectious period. For the same groups, medical, hospital, ED, private doctor visits. Again, all three groups, we'll talk about work-related settings. For the adults and adolescents, we would want to focus in addition to perhaps school settings. For adolescents, perhaps we could focus on juvenile detention centers. For adults and elderly, any exposure in shelters during the infectious period. Again, adults and elderly, any correctional facility exposure. And for the elderly, long-term care exposure. And for adults, perhaps drug treatment centers. So these are just examples of sites that we would want the healthcare worker during the interview to focus on in addition to collecting household and social contacts. Once it's been determined that a setting, investigation recommended, the index case has been informed, management now needs to be notified, and that's done through the highest ranking manager or administrator, and hopefully the name will be given to us by the patient. The notification should ideally occur 1 to 2 business days after healthcare workers informed of the congregate setting exposure. The telephone notification is preferred method to notify management and schedule appointment for face-to-face meeting. I think we all agree that the mail is too slow, impersonal, and unreliable. Unscheduled visits or emails are generally inappropriate. Just recently, I had emailed several directors of microbiology in this county, informing them of a new procedure in our clinic. And I didn't hear from one director, and several weeks after the email I had sent, I called to find out whether he received the email. And I found out from one of the colleagues that The director, when he receives emails, if he doesn't recognize the sender's name, he deletes the email without opening it. And so we know that people, in addition to that, perhaps do not read the emails on a timely basis. So a phone call is the preferred method. Providing patient's identity and diagnosis over the phone risks violating medical privacy. We do know that programs do that, and they've experienced success, but we think it's risky to release the identity of the patient over the phone. The telephone is inappropriate means to provide TV education. You never know if the person on the other end of the phone is paying attention to you while you're talking, and you don't know if the patient, what the person's going to do when they hang up the phone, who they're going to talk to, and what conversations they're going to have with coworkers. However, the initial phone call does allow for the opportunity to begin the process of building trust and rapport with management. So in a very brief period of time, on the phone, healthcare worker must project a sense of professionalism, sensitivity, and expertise. And I feel that what you say and how you say it can set the tone for your relationship with management, and I contend that the initial phone call is just as important as the initial management meeting. This is a sample of the agenda that we would include for the management meeting. It does allow for orderly discussion focusing on relevant issues such as the purpose of the meeting. Whatever you couldn't say over the phone, now everything is on the table. Patient's identity, if you decide to release it, the purpose of the meeting, the exposure. Certainly talk about issues concerning patient confidentiality. That's when the patient consent form is put on the table. And as the gentleman from Philadelphia alluded to, we also, if we release the patient identity, we also bring out the management agreement form. And I'll discuss that in a minute. We also discuss potential media interest. It always amazes me how when we go to these meetings that management is not thinking media. But when we bring it up, you can see their faces change color, because one thing they don't want is the local newspapers calling them and having a panic in their setting. We discuss basic TB education. We request a site tour. We also provide an overview and discussion of a very specific patient information, such as the basis of the patient diagnosis, the current medical status, the level of infectiousness, explanation of the infectious period and its role in the contact identification process. One of the questions that's always asked is, how do we know the patient's ready to return to work, for instance, or to school, and how do we know they're not contagious? Well, we explain the use of DOT to help ensure adherence to treatment when the patient is cleared to return to setting. And if applicable, we also discuss legal ramifications of index case and contact non-adherence. Several years ago, we conducted a national survey of the states surveyed. Greater than 90% of the states indicated they had TB regulations addressing pulmonary and laryngeal case adherence, but only one-third of the case surveyed indicated they had TB regulations addressing contact non-adherence. So clearly, two-thirds of the states could not mandate contact adherence. So this is good to know what your state regulations are in case it comes up in a meeting with management, and management says, well, what if a contact refuses to be tested? What can we do? So in New Jersey, for instance, no contact can refuse initial and post-exposure testing. Some states, however, contacts can refuse and cases closed. In addition, there's a general discussion with management focusing on the environment of the congregate setting, which is confirmed by the site tour. We ask about the total number of individuals associated with the setting. We explain local health department standards of practice for identifying and testing identified contacts, meaning we are attempting to identify the high priority contacts, not so much the worried well. That's always a question, can anybody be tested? We like to focus on the target group first, which is the high priority and medium priority contacts. We also discuss the provision of education sessions to all employees or student parents, discussion of initial and post-exposure testing. We offer an explanation of on-site, off-site testing, meaning who will be administering and reading TST, whether testing will take place, and any follow-up testing that's needed. On a case-by-case basis, release of identity may be indicated. If identity is revealed, a signed agreement to maintain patient confidentiality should be obtained from management. This is the form I referred to earlier. If we release a patient's identity in the management meeting, we ask management to review a form, a standard form we have, and they sign it, and they are obligated to protect the patient's medical right to privacy. Okay, so after the management meeting, we certainly would conduct the on-site assessment, and it helps determine potential for transmission and exposure. The assessment ideally should include accurate and detailed drawings and the photographs, with emphasis on the room design, room sizes, ceiling height, type of ventilation, and proximity of individuals in relation to the index case. And we're going to take a look at a couple examples of these diagrams and how they can be done. This is a hand drawing, a sketch of a kitchen area in a restaurant that was actually done a few weeks ago. As I'm walking around, I always carry with me a pad and pencil. Hopefully you do the same. And I just I sketch out the environment. Just simply put, this is a rough draft, as you understand, as you can see. This is the kitchen area. I measured you can see where in this big open space on the bottom where it says wait staff, or waits for food, in my handwriting, it's 7 feet from one wall to a shelf where the wait staff waits for the food to be brought out from behind the counter where it says grill. Our index patient is where the asterisk is. He was negative on BAL smear, MTB culture, cavitary disease, questionable cough. We just learned he's MDR TB. But this is what his assignment was. He stood by these 2 grills making hamburgers. And I also measured 3 or 4 feet from the grill to the back wall. It's 21 feet, the length of the kitchen area. It was stuffy back there, but in the front, it was open and airy, and the wait staff really had very little exposure to him except for when they were standing by the window waiting for the food. And what would happen here is that I would come back and give this diagram to our user support specialist, who would then convert it to graphic art. The next diagram is of a different investigation that was converted from a sketch to graphic art. This is a daycare center that is a very intriguing case. I'll just run through it real quickly. The area on the right, this daycare center was in the basement of a church. And as you walk down the steps here, enter the daycare center. For those who know me, I'm 6'3". You can see on the bottom it says ceiling height 6'5". The hair on my head touched the ceiling. I knew right away we had a problem. There was no windows, no ventilation. On the right-hand corner here was a box fan, which is the worst thing to have when you have an infectious case nearby. It just keeps the bacillus in the air. The index case was 3+ on smear, cavitary disease, cough, and I was told was a volunteer in this daycare center for, quote-unquote, just a couple hours a week. When I received the report from the hospital, I notified the manager. I called the manager of the daycare center, who happened to be the sister of the patient, and she immediately told me that, I know why you're calling. It's about my sister. She has TB. She's in the hospital. So I didn't break confidentiality, but I didn't mention the sister's name for the rest of the conversation. We just talked in circles. The director told me that, yes, her sister was a volunteer, had very little exposure with children, did secretarial work. Her desk was in a separate part of the daycare center, and the only exposure she may have had was when she went to the play area to hang up posters for the children. Well, when I did the on-site assessment, as I said, I walked in the basement and I saw how the environment was very conducive to transmission. And this is the play area here. This is the children had their desks where they played TV, bookshelves, things like that. When I walked through this office, this is where the director had her desk, and this is where the index patient sat. And look what room she's in. She's in the same room as another play area. So what the director told me was erroneous information. There was exposure to children. There were 30 children in this daycare center, all 4 years of age, 5 adult workers. And what we found of the 30 children, 40% were TST positive, all U.S. born. Of the 30 children, 5 were diagnosed as TB cases. 2 of the 5 were negative on skin tests, but had abnormal chest X-rays. In addition, 2 other cases of children 6 years of age were diagnosed with TB cases. A total of 7 cases of children 4 years of age and less. I think the emphasis I want to make here is that this case illustrates and underscores the value of on-site assessments. You cannot or should not attempt to conduct a congregate investigation or assessment over the telephone. Because if I had done that, I would have never known that the index case sat in the same room as children. And we would have just perhaps, if this program was operating differently where I am here, we perhaps would have disclosed the case as no exposure. But this case itself illustrates the need to contact management, set up a meeting, and go see for yourself where the exposure and transmission may have occurred. The next diagram, well, that's not a diagram, it's a photograph, another method of doing this. This particular investigation was a coat manufacturer who occupied 3 floors in a factory, 225 employees, and the index case also, I think, was 2 or 3+ on smear. We collected about 15 or 20 photographs. I just selected this one to show you that in the rear is where the patient, this is the work table, the patient was all day, putting together either sleeves or collars on coats with the coworkers. And this is a big, roomy area. The square footage was several thousand square feet on each floor. But I just wanted to illustrate that this is one way of collecting information and bringing it back to your site to make a decision if it needs to be tested. Here it was pretty clear that we tested the workers at this table because they were stationary, they didn't move about. It would have been a problem if they went on all 3 floors, but fortunately in this particular case, the index case was stationary at this table. These types of diagrams or drawings helps healthcare workers to accurately recall the setting for review at a later date. Based on the information gathered during the assessment, healthcare worker can provide recommendations regarding identification and testing of high-priority contacts. And whether decision-making is yours alone or in consult with the supervisor or medical director, these diagrams or pictures can play an important role in identifying contacts in a large-scale setting. Are there any questions to this point? Any comments, observations?
Sometimes I'm a nurse and I go out into the field with the large-scale investigations. And one issue I have concern with is testing the word well. I have to say I do crumble on many occasions when pressure from management or, say it's a school, identify more people to be tested. How would you handle situations like that?
Well, the question is, in large-scale investigations, it's very common for management to raise the issue of how about testing everybody, particularly worried well, in addition to the high-priority contacts. And the response is, while we understand why people want to be tested because they're concerned, what we like to do is focus on the target group first, which is the high-priority contacts, and let us see what we find there. In addition, we emphasize the education sessions that we provide prior to testing, and our experiences, and as I would hope experience out there in the states that are listening, experiences that when you provide education sessions, that the worried well and even the high-priority contacts feel less anxious when you provide them with accurate, good information about how TB is spread and not spread. So my answer is we are sensitive to the question and the concerns, but we are more focused on the people at most intense exposure first, and let's see what we find. Then we can move into outer circles. And actually, we don't like to turn anyone away, but we do encourage people, if they want to be tested immediately, if they're very well, that they should seek out local health department or their primary care physician.
I have a question. When you talk about doing schools and things like that, how do you handle the media in a situation like that?
There's a question concerning school investigations as relates to media interest. As I showed early on in one of the slides that we always bring on the agenda, we always talk about media interest, and what we suggest to management, no matter what it is, school or workplace or shelter, whatever it might be, that if the media does contact them, that we prefer either a conference call with us and the site, and or refer it to their, if they have, a media person to answer all questions. We do emphasize that the media is interested in only one thing usually, and that's revealing the patient's identity so they can publish the identity, which has happened to us before. So whoever handles the calls from media has to be very careful. We explain that media can be very manipulative, and they can trick you into saying things that you don't ordinarily want to say. So we prefer the calls actually come to us so that we can handle the calls in the way that we think is best.
And one other question. Concern about a patient losing their job because of something like this.
Patients do, the question is, at a workplace, patients are concerned if we do go to the workplace that they're concerned about perhaps loss of job because of the revelation of the diagnosis. There are regulations, there are laws that prohibit the firing of people for medical reasons. However, my experience is we do know patients who are fired after these investigations or during investigations. When we questioned management about it in a very sensitive way, we were told that the patient was fired for unrelated reasons. So current CDC guidelines indicate that in the congregate setting, contacts should be characterized as high priority if they have been exposed to a suspected or confirmed pulmonary, laryngeal, or pleural TB case who was diagnosed with a positive smear or cavitary disease. And medium and low priority contacts should be reserved for possible expansion of the investigation. This is the concentric circle that everyone is familiar with. It is important to note that in the guidelines published last year, there's not one word mentioned about this concentric circle principle. The consensus seems to be that it's losing favor and support from CDC, but all of us in the field, whether we're conscious or unconsciously, we use it. Basically, what this says is that each one of these circles represents an area of closeness, a level of closeness to the index patient. So the first circle could be household, social, work-related, school-related contacts, that the exposure could be more intense. And each circle, as it proceeds outward, represents levels of closeness on a less frequent basis. So what this concept tells us is that really the closer you are in place and space and time to an infectious patient, the more likely you may become infected. And the further away you are in place and space and time from the index patient, the less likely you may become infected. However, what we are learning, the caveat here is that we are learning from DNA fingerprinting that perhaps transmission may be occurring on a more casual basis, so the people in the outer circle may be at risk of transmission and are becoming infected from the index patient. So I think the word here is we should be very careful of who we include the circle and who we exclude from the inner circle. Any questions about the concentric circle? We already discussed this earlier, the transmission probability assessment. This identifies contact tracing priorities within the infectious period based on the following characteristics. Time of contact, we talked about the person, meaning the index case, how infectious is the person, and what is it based on? Positive smears, cavitary disease, cough, the place, that is the environment where exposure occurred. Was it well ventilated, poor ventilated? Was it indoors, outdoors? The time characteristics, duration, frequency of exposure. Was it one-time exposure during the infectious period for a half hour? Or was it multiple exposures during the infectious period for several hours at a time? And of course, we discussed earlier the contact risk characteristics. Are they children, as in the daycare center? Are they elderly, as in a nursing home? Are they immunocompetent, immunocompromised? Is their lifestyle stable, or are they transient? And of course, we all know there's problems and challenges associated with these large-scale investigations. There's potential for a large number of identified contacts at workplace, factories, schools. As we all know, these sites have multiple or many people that we have to sift through to determine really who is a close contact or high-priority contact. Potential for vague information for determining contact priorities. Typical example is a factory or a plant of some sort where the patient may not be stationary, may move around from site to site. One day maybe on an assembly line, next day maybe loading trucks, next day doing something else during the infectious period. Potential for incomplete identity and locating information. I think when someone leaves the workplace, they may give a phony or false address, or they may be moving around a lot and we can't find them or have difficulty finding the patient. They may be using an alias, as was mentioned earlier. Challenges in maintaining patient confidentiality, always an issue in these investigations. That's why, on the surface anyway, the forms that we mentioned earlier are very beneficial to programs. However, we all know that patients can be their own worst enemy, and they can violate their own medical privacy and tell their coworkers or schoolmates, and then everyone knows the name, and everything we do is basically damage control. Collaboration with officials and administrators who are unfamiliar with TB. It always interests me that when we go to these sites and speak with management, for instance, whether it's an attorney at a large law office or a CPA or a president of a corporation, I am always interested in how they think their expertise in their field suddenly can be transferred to expertise in public health. And so it's our job to convince those experts that we are the experts in TB. And of course, media coverage we discussed earlier, and how to handle the inquiries from media, and how media coverage and how the media is always lurking and ready to pounce on us when we are unexpected. Notification and testing of high-priority contacts. Consideration should be given to notify all high-priority contacts and others associated with the congregate setting regarding potential exposure. Information and notification letters are sent. These are pretty common to programs. For instance, if there's a school with 1,000 children in it, perhaps the investigation has identified 200 students and faculty that need to be tested. Many programs send out 800 information letters informing the parents and faculty and students that there was exposure at the school, but they don't need to be tested. But then 200 notification letters would go out indicating to family and students and faculty that they do need to be tested. So these types of letters are sent out, and it is a decision that's made by each site whether they want to inform everybody or just the immediate circle of contact. We believe that it's good public relations to inform everybody, because I think it's very risky to keep that type of information confined to a small group of people, because everyone talks and word will get out and management will look very bad in the end. Scheduling of testing, time, date, and location of testing of all contacts should be scheduled in advance. Testing of high-priority contacts, testing and medical evaluations for contacts should take place within a time frame consistent with current CC recommendations. The new range is 7 to 17 business days, depending on the index case smear and X-ray results. Just a quick explanation for those who aren't familiar. The high priority contacts who are contacts with smear positive or cavitary disease index case. 7 days from the day the contact is identified, we have to administer TST. We have additional 5 days to complete the evaluation if needed. So if an X-ray is needed, we have 5 additional days, which totals 12 days for that particular contact. For the high priority contacts who are contacts with smear negative index case, we have the same 7 days to administer TST once the contact is identified, but 10 days to complete the medical evaluation if needed, for a total of 17 days. For medium priority contacts, regardless of smear results of the index case, 14 days to administer TST, and 10 additional days to complete the evaluation if needed, for a total of 24 days in total. And actually, those recommendations are really not practical for large-scale investigations, because, as you know, it can take many days, if not a week or two, just to sort through who's a contact and to set up testing. So I think those recommendations really refer to small-scale investigations of household and small investigations in general. Education sessions allows individuals in a congregate setting to become better informed about TB exposure, transmission, and treatment. We believe effective education sessions held prior to testing appears to help reduce anxiety for those identified as high as well as low priority contacts. We're currently involved in a study here at our center that's attempting to measure the level of TB knowledge before and after education sessions, in addition to measuring the level of anxiety before and after education sessions. So we're curious to see what those results show. The provision of basic TB education and management may include how TB is and is not transmitted, factors influencing transmission, the difference between infection and disease, discussing treatment for infection, disease, and importance of adherence, and DOT as it relates to the role of TB control. Provision of education to individuals in the congregate setting other than management may include the same information as we provide to management, but should include a visual component of slides overhead or printed education materials that are available through CDC. Determining when to expand a contact investigation, consideration of the following factors is recommended. Achievement of program objectives with high and medium priority contacts. Just to list some statistics from CDC as to illustrate what this bullet is attempting to improve. In 2003, the most recent year that we have final data from CDC, in the United States, 14,852 cases were reported. Of those, 5,233 were sputum smear positive. Of those 5,000 cases, 73,300 contacts were identified. The national objective is 95% of all contacts should be evaluated. In 2003, we attained, as a nation, 80% or 58,000 contacts were evaluated, meaning 14,600 contacts were never evaluated. So what happened to those contacts, we have no idea. We'll have to follow up. Perhaps states didn't have regulations mandating contact follow-up. But the point is that if programs are not doing well with their high and medium priority contacts, then it really doesn't make sense to expand to low priority contacts. However, if there's recent transmission in identified contacts, we're looking for unexpected high rate of TST results or evidence of secondary cases or transmission to contacts less than 5 years of age or documented TST conversions or change in TST status from negative to positive. If any of these occur, then that gives a program it gives consideration to expand the testing to the next circle of contacts. In absence of recent transmission, investigations should not be expanded. The closure investigation should be consistent with local health department standards of practice. For closing a contact investigation, that should be dependent upon completion of initial and post-exposure testing and all medical evaluations of all identified contacts. Actually, that is the completion of the talk, of the discussion of congregate settings. I do have a brief case I'd like to review with you. Before we do, however, are there any questions or comments or observations? All right. This is a case of, and by the way, I just chose this case to illustrate some of the concepts that we just discussed. This is a 25-year-old foreign-born male. Initial visit to primary care physician with complaints of productive cough for 1 week with night sweats and fever. TST was administered, was raised 20 millimeters. X-ray was cavitary with right upper lobe infiltrate, and at the private doctor's office, no sputums were collected, which is not unusual. Treatment several days or a week later was started with 4 drugs, rifampicin, INH, pyrazinamide, ENB. And a few days later, the patient was referred to outpatient TB clinic for follow-up. the medication was continued, and sputum times 3 was ordered. So I would need some participation from the group that's listening. If you were assigned to review this case, what would you be thinking, and what would be your plan of action at this particular point? Would you take any action? If not, then what would be your rationale? And if you would initiate action, specifically, what would that action be?
Hello?
Yes.
Okay, this is Ohio.
Hi.
We finally learned how to our phone.
Okay, so do you have many more questions? We can backtrack.
Well, just if we can go back to that initial question that you had, I guess we're at the screen here. Okay.
The Think Investigate number 1?
Well, yeah.
Okay.
Okay.
Okay, Ohio.
Okay, so when it comes to if we were assigned to, to review this case, considering the fact that they were cavitary upon the chest X-ray, even though we probably at that point wouldn't have any indications on the sputum, because they were cavitary, we would go ahead and initiate a contact investigation because of the cavitary indication on the chest X-ray, even though we may or may not have the actual, sputum results at that point. And then, of course, just dealing with going from the immediate contacts and then spreading out because of their symptoms that they had with the positive cough for 1 week,
Okay.
at least.
All right, thank you. Anyone else want to contribute? Would anybody else like to contribute to this slide?
New Jersey. Mark, I agree because of the symptoms, the test administered, the abnormal chest X-ray. I would initiate an investigation on.
Okay, any other comments?
We often find if there's a spouse, especially, or someone that comes with them to their appointments, or that we can get better, accurate information about symptom review from the significant other.
Okay, but that's accurate. Based on the fact that this person had a cough, this came from the private doctor's office, cavitary disease. Based on that alone, let's assume this is reliable information about the cough. No sputums were collected. If you had that information in your hand, what would you do with it? Anything?
Wouldn't you want to isolate him and collect sputum?
Yes. Yes, you would. Actually, everybody's correct. What we did was we initiated a contact investigation based on X-ray results and symptom history. And essentially, when the patient arrived in our clinic, we did put him in our airborne isolation room. Interview was conducted to identify 5 high-priority contacts for household and 1 social. We also learned that the patient was employed at a mattress factory. And based on information that we gleaned from the patient or obtained from the patient, we developed 2 infectious periods. One infectious period was for the work-related exposure. August 20th represents the last day of work at the workplace when contact was broken. And the second infectious period represents exposure to household and social because the patient was not hospitalized. Index case during interview did sign consent to disclose identity at workplace if needed. So, if you were the healthcare worker assigned to this case, what would you be thinking and what would your plan of action be at this particular point? No action? If not, what's your rationale? Take action and recommend on-site assessment of workplace? And if yes, what would be your rationale for that? Now we have a patient who was identifying contacts. No one's been tested yet, but certainly the cavitary disease and the cough, and now explains that he was working during his infectious period. Would you recommend an assessment of the workplace, or would you wait for smear results, TST results?
Probably looking at the TST results of the immediate household members, because of those, that's where he was the most often, for maybe possible longer period of time. But the fact that he had the cavitary, that could be indication. That's definitely the other indication to probably test the mattress factory. And because of the cavitary, and maybe even at this point, we might have results of the sputum, depending, they may or may not be positive, who knows, but because of the cavitary, I would say yes. Absolutely.
Let's go on the assumption that you do not yet have the SME results, nor the TST results. Are you saying you'd wait for TST results before you go to the workplace, or you would go anyway?
I'm not sure.
Okay.
I mean, I'm partially inclined to maybe wait to see what the results of were the household, but the cavitary kind of sticks in my mind, and because he was, definitely working, in the area, who knows, I would consider anyone he would possibly be working with or next to be considered, a high priority because of the length of time that he was probably with that person that he might be working next to.
I think we have to remember that the on-site assessment does not mean you must test. You're just going to the site to assess whether you think exposure and transmission may have occurred. So it's not a wrong thing to, CDC does recommend that within 5 days all sites should be assessed for potential exposure and transmission. So many programs do wait for the household contacts to be tested. There's no right and wrong way here. I'm just curious what programs are thinking and what their standard practice is. So you would like to wait for TST results, but you're concerned about the cavity and the cough.
But sometimes the household contact, Christian from New Jersey, but sometimes the household contact, most of them, work, and they spend like 16 hours, outside, and then spend only maybe 2-3 hours when they see each other. So then the job site probably become more of a high priority.
Yes, that philosophy is shared by many programs. Like I said, some programs do wait for household results as a barometer and as a gauge to see what the next move is, and other programs agree with Christian that the exposure at home may be less intense and more limited than the workplace. As we know, many people are at the workplace for 10, 12 hours, and their home, perhaps the exposure is less intense and less in terms of time.
I'm sorry, Tim from New Jersey. In reviewing this particular case, I don't know about anybody else, but I think that I would also call, because of the primary care physician's office and the patient being in and out there with skin testing and things like that, I think I would also kind of question the primary care physician as to how long the patient sat in the office, and maybe do a visit to the office just to see what type of office or the environment they have there also, and what kind of patients come in and out of that office.
That's a good point. We always have to remember that patients waiting in doctor's office who are undiagnosed and who are infectious, that's another site that needs to be explored. Our experience here in New Jersey, at least our investigation, is that even with laryngeal TB patients sitting in the waiting room, we find very little transmission occurring in doctor's offices, fortunately. And it's hard to believe because many of us wait for, several hours in a crowded waiting room, maybe several times during the infectious period, and we see no transmission occurring even amongst high-risk patients, high-risk contacts. But it is a site that we'd have to consider for an assessment with the private doctor. What we did, basically, we did not wait for TST results, nor did we wait for sputum smear results. We felt as if, as Ohio feels, that we were concerned about the cavity and the cough, and we initiated the on-site workplace assessment based on index case X-ray results and symptom history. While we were actually the day that we were doing this assessment, we were informed that 2 of the 3 sputum samples were positive on smear 3+, and that all specimens were identified as NTB on final culture, and that the sensitivity indicated that the patient was pan-sensitive. And we also learned several days later that 4 of the 5 contacts were positive on TST with no disease. So we initiated a telephone call to Master's Faculty Management. I was very brief and vague, yet enticing and convincing how important it was to set up a meeting to meet with the management. Face-to-face meeting was scheduled for the following day. Management meeting followed the prearranged agenda that we had recently showed on the previous slide. Management did sign a confidentiality agreement, and in this case, identity was revealed. Subsequent discussion of contact identification, testing, provision of education sessions, and notification procedure was discussed if determined necessary to be used in the future. And of course, the site tour was conducted. And this is what
we found on the first site tour. This is, as I said, a mattress factory, 240,000 square feet. Ceilings were 26 feet in height. There were 3 exhaust fans in the ceiling, and the exhaust fans were huge. They were size of any room that we're all sitting in right now. There were 3 air exchanges per hour. The index case worked on a 3 to 12 p.m. shift with 111 employees. This workplace was divided essentially in half. The back half where 97 employees did packing, handling, and shipping, and did all kinds of, on the left-hand side is the cargo bay doors where trucks were loaded with mattresses. In the frontier, the index patient's workstations marked with the red cross. There were 14 employees who worked on this conveyor belt where they put together mattresses. The area where the mattresses were put together was approximately 50 by 50 feet. Over to the right, time clock, is a locker room that was 18 by 30 feet, a lunchroom 30 by 38 feet, very small, very stuffy, no windows, ceiling height was 10 feet in each room, and the maximum capacity for each room was 50. The question is, if you were the lead person during this congregate setting contact investigation, what would your plan of action be at this particular point? Test? If yes, who? And what's your rationale? And if no, what's your rationale for not testing? Or perhaps you're not ready to commit at this particular point. Do you need more information? And if so, what would you like to know? And what would you do to find out?
This is Ohio. We would go ahead and test the 14 people that were in close proximity and also try and obtain information about who went to lunch together and when.
Ohio, could you speak louder, please? That was a good comment.
We would go ahead and test the 14 people that were in close proximity and then also find out who went to lunch together since it was such a small room.
Uh-huh. Okay, to answer the latter question first, we found out that regarding the locker room, the index patient, his shift started at 3 p.m. The index patient claimed, and we believe him, that he arrived at the workplace about 10 minutes to 3, went to the locker room, changed real quick, and went to his work site. And at 12 o'clock, he went back to the locker room and was out in 10 minutes. He didn't like to stay in the locker room because he was a non-smoker, but everybody else was smoking, and it was stuffy in the locker room. As far as the lunch is concerned, he did not attend the lunchroom for the same reason that it was small, crowded, and stuffy. Everybody was smoking. So depending on the weather, he would either go outside, and remember the infectious period was warm weather in New Jersey. I think it was May to September or August, so that's warm weather. So he would eat outside many days. On the days it was raining or chilly, he would come inside and eat on his workstation, which was a big table. So knowing that, you would still want to test the 14 people who were on the conveyor belt. By the way, they were all these workstations were approximately 5 feet apart from each other, and across, I think they were approximately 10 feet across from each other. So your recommendation would be test all 14 people, or 13 people, really?
Yes.
Okay. Anybody else?
I agree.
And where are you from?
New York.
New York. Okay. Okay. This is what we chose to do. And quite frankly, if I was to do this investigation over again, I might agree with you that we would do all 13 people. But at that particular time, I developed an inner circle of people. And so we tested the first circle, 7 people. What I thought were the 7 people, by the way, they were stationary. These workers did not, on a regular basis, did not float from workplace to workplace. So their stations were pretty stationary. So I chose 7 people who I thought were the closest, and it really was an arbitrary decision, quite frankly. But what we found was that 3 of the 7, 43%, were positive on TST. And of those 3, one is foreign-born, 2 is foreign-born, all 3 were foreign-born. Correct? 1, 2, 3. Yeah, all 3 were foreign-born. However, in a circle, 2 additional foreign-born contacts were negative on skin test. There were a total of 13 workers potentially exposed on assembly line. 7 contacts were identified in testing. 3 were tested, and 14% were positive TST with no disease. So now, what would you plan, knowing this, what would your plan of action be? Expand the investigation to remaining 6 people? Or, if yes, where else would you expand? And if no, why not? Or would you stop the investigation there? Ohio, we need you.
We would go ahead and test the other 6 just because the percentage rate is high even though they are foreign-born.
Okay.
I think we would go ahead and expand and test the other 6.
And how about New York?
Yes, I would do that too.
Okay. Anybody else? Would anyone stop the investigation?
Christian from New Jersey, can I ask a question that I don't see addressing here? During his commute, he, accompanied with any of his friends that work at the factory when going to work?
There was one person who did commute with him. The index case did not drive, did not have a driver's license. And one of the coworkers did drive this patient to and from work every day.
Was he one of the, Jim from New Jersey, was he one of the positive skin tests?
Well, we'll find out. Good question. Well, yes, we did expand, obviously, to remaining 6 people. 6 people, yes, and 2 of the 6 were positive on skin tests for 33% reactive rate. So that the red represents the inner circle, yellow represents the second circle. Foreign-born, native-born are next to each red or yellow box. And so we are still seeing 33% reactive rate. And of those 2, one is foreign-born. One foreign-born did convert. Could have been a boost, but we're not sure. So we have 2 foreign-borns, two foreign-borns who are positive on skin test, and 1 foreign-born who was negative, 2 native-borns who are negative. 2 foreign-borns who are negative. So the expansion included 6 remaining coworkers on the assembly line. As I just mentioned, 2 of the 6 are positive on skin test with no disease. So now we have a total of 5 coworkers, which is 38% were positive on TST results and no disease. So now what's your plan of action? Expand investigation. If yes, where? What is your rationale? If no, what is your rationale for not expanding? Would you stop the investigation? If yes, if no, what would be your rationale?
This is Ohio. We would go ahead and stop since the building is so large and with all the exhaust fans and it kind of being partitioned off with the other workers, we would go ahead and stop at that point.
Okay. How about New York?
Yes.
You would stop as well?
Yes.
Any other comments from the states? New Jersey, any comments?
Yes, I would stop also.
Okay. So here's the outcomes. Congregate setting contact investigation was stopped. We felt as if all high and medium priority contacts were identified and tested. Of 13 employees evaluated, 10 were foreign-born, 3 were U.S.-born. Of the foreign-born, 5 were positive, 5 were negative, and all 3 U.S.-born contacts were negative on TST. And all post-exposure TST results remain negative. At the time, it was 90 days later. Now, of course, the recommendation is 60 to 70 days later. I think one thing I find interesting about this case is that the question of BCG, these foreign-born patients were from South America, and they gave history of all receiving BCG. And I think this is an example of some of the cases that we're coming across where the contacts are from countries where BCG is given, where we're finding many of these contacts are negative on initial and post-exposure testing. And I think that is showing us that perhaps it's true that the BCG protection is waning over time, and that it's a myth to believe that BCG offers lifelong protection to individuals, as some private doctors are telling their patients. Our executive director, Dr. Reichman, stated several years ago regarding BCG that millions of people in India get BCG, yet millions of people in India get TB. And so how effective can the BCG really be? And so as a result of this stopping investigation, the investigation was closed. Just some closing thoughts today. While some contact investigations are considered routine, uncomplicated, and uneventful, others can be complex and require careful thought. However, regardless of the size and focus of the investigation, all should be the result of comprehensive planning. The first error we can make as disease investigators is to assume a cavalier approach. with the expectation that a contact investigation would proceed trouble-free. The second error is to be unprepared when we realize how wrong we were. Thank you.
Thanks, Mark. Very interesting discussion. I would like to ask now that you guys can unmute your phones and ask any questions you have about anything that you heard, or you want to make comments or anything in this particular presentation.
New York, and I want to thank you for your presentation.
Thank you.
I had an interruption, and maybe I missed this, but did we find out if the person who was transporting this individual back and forth, was he one of the positive cases?
Thank you for bringing that up. I meant to mention that. If you look at the slide, this person right here, who was actually reserved for the second testing, was positive on tuberculous skin test, and I was curious as to why that was. I was also curious why the person. We think the person in front of him was a boost, but we're not really sure. But anyway, the person who has a positive skin test that's circled here was the person who did provide the carpool, the transportation, and also was a close friend of this person at the workplace. And actually, every day that they ate inside having lunch, they would sit on the same workstation every day and have lunch together.
Thank you.
Thanks for asking.
New Jersey, I have a comment about that. Just to see how important the concentric circle is and how useful it can be. Being that one, on the expansion of the testing, the driver was picked up in the expanded testing. I wonder if we hadn't done it like that, if he would have been missed.
Well, what I was thinking when we realized who this person really was, you know, if you think back, technically that person should have been picked up on the interview as a social contact and a workplace contact. So perhaps the right question wasn't asked at the time by the interviewer, but we can't fault the interviewer for that. The patient may not have wanted to give the information out, but that's why it's important when interview is being conducted, we need to ask patients all the questions that are possible, because the patient very rarely will volunteer information to us. We have to ask very direct questions and be very persistent in our questions without turning the patient off. But if we don't ask it, we're not going to know. Yes, any other questions?
Yes, this is Edgar Nicholas from New Jersey. My question is, determining when an expansion from a contact investigation, let's say if you have a patient who's been on medication for 3-4 months, and all of a sudden he came up with a positive smear or culture, should a contact investigation be reassigned? And also the second question, what would cause that? Because if he wasn't treated, there was an improvement, while taking medication, and all of a sudden, he becomes smear or culture positive.
Well, for someone on treatment for 3 months, and depends what the sensitivity is. If someone is drug resistant, then that indicates that the treatment was inappropriate, and infectiousness could continue. If someone is drug sensitive and they suddenly have a positive smear, it could be a non-viable organism, and it's meaningless in terms of exposure. However, if someone clearly is positive on smear, suddenly is positive on smear goes out MTB, there is no improvement on the X-ray, then I would say that, this is really a question for a physician, but it would sound like maybe if the person's adherent on DOT or not adherent on DOT, perhaps there's a drug absorption problem, something that should be consulted with the medical director. But to answer your question, if it's true someone now is contagious again, then the investigation should be reopened. And a new infectious period, new contacts, new exposures.
Christian from New Jersey. Reference to the consent form, worksite consent form. Have you any of us encountered problem where the management refuses to sign the consent form or allow you to come to the facility for investigation? And how do you handle that?
Well, no one really responded to that. Maybe people having problem unmuting. But if someone uses consent forms and also uses the management agreement form, we appreciate a comment. But in New Jersey, my experience is we've been using it for 5 years, never had management refuse to sign the form. Because the form itself really is an educational piece. It's not just a form. It describes what TB is, how it's spread, how it's not spread, the importance of protecting patients' medical right to privacy. And so it explains things step by step so management understands the issues at hand.
Ramona from New Jersey. Mark, if you can just elaborate on the technique that's used when testing on site to keep the patient confidentiality if the patient is on the job at that time. For example, testing the patient.
Yeah, I think that most programs use the system of calling the index patient in to the private room, administering a TST that is, I think, saline solution. I'm not really sure, saline solution, or not administering it and just making believe it was administered, so they walk out of the room holding something on their arm, and then they come back, 48, 72 hours later for the make-believe reading. So we do what it's happened before to all of us, I'm sure, that the index case is back at the site when we do the testing and education sessions, and so we just need to divert attention away from the patient as best we can and proceed as if we normally would, as if the patient wasn't there.
Lillian from New Jersey. I'm a nurse. My concern is, and it did come up, confidentiality is very crucial. Many times I've found that the family tends to break confidentiality by telling either the supervisors on the job, or if it's a school, which I've been involved with, other students in the school. So I think we need to also stress to families the importance of confidentiality, that they don't need to tell people about their disease process or what's going on, because that's been my experience working with children, that they tend to tell other students, tell teachers, principals, that they're a tuberculosis case.
Well, I think, as I listen to you, I think that I'm not sure why patients do that or families do that, except for the fact that maybe they think they're helping us in our investigation. Maybe they want more people to come in, and the people come in are worried well. They mean well, the family, but perhaps they overextend themselves by having too many people know the business of the patient. Mm-hmm. Any other questions or comments?
Well, we would really like to thank all of you for participating, and we hope Ohio, New York, and New Jersey do not feel picked apart, but we do appreciate all of your questions. And once again, we would like to thank Mark Woolman for his expertise. And finally, please note that there are several resources related to contact investigation, congregate settings, available on our website, which is www.umdnj.edu/global-TB. This concludes our web conference. Thank you once again for joining us.